Hello. Uh, Good to see you all here again. I'm going to share my screen and then we will start the presentation. So everyone can see, right? Maybe let's start. Okay, so very nice to see you guys and happy to have me here in the webinar. And I think because I'm not speaking Indonesian, maybe I say like a few sentences and then you translate, right?
Yes, doctor.
Mm-hmm. Okay, so I think I've been just now introduced through the Indonesian, and I'm the head of training in Southeast Asia for the Inventis equipment. And first of all, let's begin with some agenda, what we are talking about today. First of all, we are going to talk about some clinical foundations, some review, some very general review of the clinical foundation of what evoked potentials are. And then we are talking about the equipment, like what kind of equipment you're using and the licensing, what kind of license you'd like to have for different setup. Okay, so we talk about the modular architecture. And then we are going to talk about the system configuration, like what to go for together with the equipment so as to run the test smoothly. And then we are talking about the strengths of the current equipment, the Celesta, and we talk about some positioning of how um, we use in different setups, some key messages of the how to make use of the tests to go for the diagnosis, the assessment, and then finally some improvement, some intervention for our patients. Okay, and then we'll go through some very kind of more hardcore thing is the setup, initial setup and the connection. But don't worry, it's quite simple. And we talk about the Maestro software interface. Okay, so questions of interest. When we talk about, I talked to Mr. Lears and other of the share as the stakeholders of today's webinar. We talk about for the Celesta system, what kind of patients you're helping eventually. Because there are a lot of different auditory evoked potential tests and vestibular evoked myogenic potential tests. So, what kind of patients we are helping? And then is the second, the clinical foundations. We talk about what we are really testing in human being. And then the third question of interest is the Celesta system configuration and what kind of license we available for choose. So let's move to the next part. So now for the this webinar, our aim of the questions, what we really want to know is these three directions. Okay, so let's start with the clinical foundations of the evoked potentials. I think most of the participants here are doctors and audiologists, so maybe you're quite get different level of ideas about evoked potentials. So what is AEP, Auditory Evoked Potentials? Is an electrical response of the nervous system to an acoustic stimulus. So like when I hear beep, when we do pure tone audiometry, we'll go through the ear, the outer ear, the middle ear, the inner ear, and then your nerves, and then your brain, and then you know that, oh, I hear the beep sound at your brain, and then you press the button as the response to what you're hearing. So this is a complete pathway of listening, hearing and listening. But for some cases like very young children or other people like some mentally challenging people, they can't really tell you, oh, I hear that beep sound. So we're testing the when the acoustic stimulus gets into the nervous system, what the changes of the nervous system. We're measuring the electrical response to let us know whether they can hear or they can't hear. Okay, so this is the anatomy of our nervous system, very brief one. So at the end, we got the cochlea, and then the nerve, the spiral ganglion, and the nerve, and then the spine, and then you got different parts of your brainstem, and actually at different parts of the brainstem, the nervous system connect together, of course, and we measure like for short latency, we just measure to the brainstem, and then for the middle latency, we measure up to the subcortical ones, and then for long latency, we measure up to the cortex. So for audiology, we're talking about where's the site of lesion if there's something happen in the whole system so that the patient can't hear well. So which part does it does the site of lesion happen? Which part gets some abnormal problem? Okay, so we break down to short latency, middle latency, and long latency to make sure that we can find where's the site of lesion. Okay, so this part, for the maybe if for someone who is familiar with ABR and ASSR, then we know that we are measuring the brainstem from wave 1 to wave 5. We're checking the ratios and the latency and with the amplitude of the wave 1, 3, 5, so that we know the how the brainstem's going when we hear the signal, okay? The stimulus. Okay, for the middle latency, we got the subcortical structures, and then we'll go through the V1 and 0P0, this part, the V1 to NB for the subcortical structures. We also check about the waves. And then for cortex, the long latency is one P1, N1, P2, and N2. We measure all these, analyzing these figures so that we know what's happening when the sound goes through the auditory pathway. All right. So we talk about the just now we talk about the auditory evoked potential, and then we now talk about second part in the Celesta. What we are measuring about is the vestibular myogenic evoked potential. So for this one, we check about like the lowest, like we say the threshold of what we hear. For we find the threshold and we find the morphology of the waves. So maybe like for the same level of loudness of the stimulus, does it different when compared with the notes? But for the EP, the vestibular myogenic evoked potential, we say the VEMP. We in fact checking about the reflex response, not the cortical recording, not to the cortical, the reflex. Like after the stimulus gets into your nervous system, and there's some automatic reflex response, not controlled by our brain, not controlled cortically. So it's more subjective, more subjective. In fact, for the auditory evoked potential is also subjective, and the VEMP is subjective. Compare with like the pure tone audiometry, the pediatric pure tone audiometry, and some speech audiometry. They are kind of need more participation of your patient. But for this one, the auditory evoked potential, the VAMP, they all very objective. Okay. So we talk about the CVAM and the OVAM. For CVAM, it evaluates the secondary and the inferior vestibular nerve. For the VAM, both of the VAM, we check about the vestibular nerve, okay? But they're different VAM. The first one is the cervical VAM. We check about the sternocleidomastoid muscle, or we say the SCM for short term. Okay. We check about the SCM. So when we check the CVAM, your patient usually do like this to make sure you can check the SCM, the muscle, okay? It's inhibitory, and we record it ipsilaterally. So you put the stimulus on the left side, and then you measure the left SCM for the response, okay? So it check about the secondary and the inferior vestibular nerve. And then for the OVAM, we are not checking about the SCM, but we check about the ocular, your eyes, okay? In fact, we evaluate the utricle and the superior vestibular nerve, also the vestibular. And then we check the extraocular muscle and the excitatory and it's record contralaterally. So your stimulus, if you want to check the ovum on the left side, you have to put the stimulus on the right. So this is called contralaterally. Okay. By comparing the right and left responses, we can detect the asymmetries and then we evaluate the integrity, how the vestibular pathway goes well or not goes well, which part fails. We check about all these with the CVAM and the OVAM working together. We check as a battery of tests, okay? So this is a table of what we are checking. And of course, we talk about the Celesta, the Italian Inventis brand, what the Celesta can do to help all these, okay? We check about, for the portfolio, we check about the ECOG, the electrocochleography, and then the ABR, the EABR. EABR is for the brainstem when we are doing the intra-operation measurement to check the EABR. And then the MLR and the LLR and the CVAM and the OVAM. All of these tests are covered by the Celesta. Okay, so we'll go further to talk about what kind of different models is useful for different setups. So that maybe if you like want to get uh, you want to make a new clinic, say you want to make a new uh, auditory and vestibular center, what kind of the tests you have to include in your center? Okay, let's think about that. And then, so this, I'm not going to go through this very in detail. This kind of may be familiar to our participants. And I just want to highlight that we for different like ECOG, the ABR and the EABR, it cover up to the brainstem from the cochlea to the brainstem. And then the MLR, we say the middle latency to the subcortical structures. And the LLR, the late latency, we cover the auditory cortex. And for the VEM, we check about the vestibular system. So for all the auditory and vestibular parts, we try to cover them. Okay. So just now we talk about different tests, and due to the different structural arrangement, they are put under different modules, okay, and the license. We have the basic license. So for the cases ABR and EABR, and then we have the AEP plus license. also the ECOG, the MLR and MLR, and then the VEMP license, and then two-channel enable to speed up the test. And then upgrade, maybe first of all you want to try, so you get the basic part first, and then later on you expand your clinic and you include the AEP plus. And then the very uh, our flagship license is the Here Lab ACA license, which is releasing supposed in June this month of 2026. But I think within this year, the third and the fourth quarter, the Here Lab ACA license, the long-awaited license, will be released. Very looking forward to it because it's new to the whole all the audiology field. New, completely new, not even in other of the our um friendly other factories. Okay, so we also include the hardware, the evoked potential system, and then the bow amplifier. Okay, if there is some questions, you just type in the chat box, and I think the our colleague will translate it to me, and then we can reply later. Okay. Okay, so for the AEP, the EP basic license, I don't know if you in your setup, like in a hospital or whatever, like maybe a newborn hearing center, the nursery, will you include the AABR, the automatic ABR for the hearing screening for newborn babies? I had been in a hospital working before in a private hospital in my region, and then every day in the nursery there are like lots of babies. Yeah, every day there are lots of babies, and they stay in the private hospital to like only 2 to 3 days. And then when we try to get some idea about whether the baby can hear or not. Of course, they are not going to give you raise up your hand when you hear subjective things. They can't really respond to the sound. They can't tell. Okay. So we have to do the automatic APR for the hearing screening. And if they pass or fail, they pass, then we go to the normal pathway. If they are not passing the ABR, the AABR, the automatic ABR, then we go through the referral pathway. Okay, so for the EP basic license, I think it's good for the hospitals who need the ABR, AABR, and then after some cases they refer, they're not passing for the first ABR in the first few days of their life, like the day 0 to day 3 of the newborn, then like after 1 month, the baby go back for the audiology clinic to do the ABR, to test whether they pass again after maybe clean up the ears. So I think the ABR is quite good, yeah. And also the EABR we talk about whether like in a cochlear implant operation, in the operation theater, in the middle of the surgery, we'd like to know after the insertion of the electrode, whether the the patient we insert, so that whether the electrode insert successfully, then we go for the EABR, it checks the impedance. Okay, so if you got some need, like you want to confirm the threshold of patients, newborn patients, or not kind of cooperative patients, like for the patients uh with, we say, um the how to say, the organic hearing loss. They're pretending they got hearing loss. Then you go for the AABR to confirm the result. Okay. So if they got old ABR system and they want to replace a new one to keep up the level of the ABR, then we suggest the EP basic license. Okay. And if you got a center, you want to open a new clinic just for audiology and not vestibular testing, then I think the EP basic is good enough. Okay, for the EP Plus with the ECOG, the MLR, and the MLR will be more advanced like in a hospital, the ENT department, or in a second level audiology center. We want to know about more any like retrocochlear pathologies. Or we say you got a patient. Um, they got they have some hearing problem, but they can't really tell. Like the pure tone audiometry goes normal, but they still report some hearing problem. Then we go for the retrocochlear tests like the MLR and the LLR. Or maybe for some uh older kids, not newborn, we suspect them to have auditory neuropathy. You know the spectrum of the auditory neuropathy. Some they are performing well, just not hearing very well in noisy situations, but they perform well in quiet situations. For the other, on the other side of the spectrum, they they pass the pure tone tests, or maybe with some hearing loss in the pure tone tests, but they perform much worse than the pure tone results. Then we go for the ECOG and maybe MLR and LLR to check for the auditory neuropathy. And sometimes we use together with the OAE as well. And we measure the cochlear, the ECOG, and maybe the cochlear microphonics. We measure a lot of this to check whether it's auditory neuropathy or not. Okay. And maybe suspected acoustic neuroma when in some remote places they're not having the MRI clinic within that remote places, then we can go for the EP plus license. We check with the ABR, the ECOG, ML, and LLR to check the pathway, the functionality of the auditory system. Okay, so the EP Plus license is helping a lot in managing complex hearing loss cases. Okay, so other than that, we got the CVEM and the OVEM, and this is very obviously for vestibular clinic. Okay, and like you got patients with vestibular problem, or they just report like I got dizziness, I got vertigo, and then if they are not very obvious problem like BPPV or whatever, and then you want to go for the diagnosis of the vestibular, which part of the vestibular system, the site of lesion, and how we can help for the rehabilitation. Then we go for the vestibular diagnostics. Okay. So for these cases, for all of the cases, if we want to reduce the test time, like in a basic clinic, then we'll also suggest a two-channel license so that we can check the right ear and the left ear. We do the uh, data acquisition together on both sides at the same time. So we can have the two-channel license. Okay, for the latest part, the Here Lab ACA license, is for aided cortical assessment. I think this is very good for when you're fitting hearing aids, and you can't really tell whether your patient after fitting hearing aid, uh, is there any real benefit after they put on the devices, like for young kids, for some mentally challenged patients, you fit the hearing aids and you still want to check objectively because they can't really tell you whether they can hear or not, then you do the Hear Lab ACA license. Okay. So the typical setting will be the pediatric audiology centers, the hospital managing complex fittings, and some advanced hearing centers and cochlear implant centers. Okay. And what's the difference is for the previous license, like ABR, ASSR, the AEP, and most of these assessment, we use some tonal signals, some tonal or synthetic signals. But for Here Lab, we use more speech sounds. So more speech-like stimulus to test the we say the verification of the benefits of fitting hearing aids. Okay. So so this is a kind of comparison. Like we use speech like stimulus are other than the artificial stimulus. So that and then the Hear Lab we use free field, we use speakers, so that to check the hearing aid device whether it can help or not. Okay, so the difference between LLR and the ACA is but LLR is a diagnostic tools to check the problem. Okay. And the ACA is a fitting verification tool to check, oh, after fitting, the benefits, the real benefits of your patients. Okay. So after we talk about the modular architecture and licensing, and then we talk about some very the system configuration and the standard equipment. Okay, so we got a very lightweight Celesta main unit, just like a laptop, 1.2 kg, and then a bow amplifier, which is also very small, uh, uh, light but uh, strong, bow amplifier. Okay, and then we have include with the Super O headphone, the DD45, the IP30 insert earphones, the power supply, the USB-C cable, the EABR triggering cables, and adapters, operators, and some consumables, and the Inventis software suites. And then the you may also add like the VEMP patient monitor, the bone vibrator, which sometimes we do ABR, we also use the bone vibrator, and then the IP30 insert earphones. Okay. And then we got the power and a lot of at the back, the rear panel of the box. You know the box. This is the main unit, and this is the rear panel, the Celesta rear panel. We got all these insert hubs. Okay, and the requirements of the power and then the PC. I'm not talking about this very in detail. Just want to tell that this part we got the light and this one is not a decoration. When it goes purple, which means the power is not stable, it's not sufficient for testing accurately. Okay. So we talk about the key strength of the Celesta. First of all, we say the power amplifier is clean and provide stable signal in even in real clinical environments. I don't know whether in the past, when we do the ABR or the ASSL for a long time ago, some other old brands, they require a very clean environment, like magnetically shield room, like in the audiology room is like in booth, a sound booth, but also electromagnetically shield because the measurement of the signals is very easily affected by some noises, some electrical, mechanical noises happen around. But now we got much better improved power amplifier, and then we can obtain some clear and stable signal in even in real clinical environments. Of course, in a quiet room, but not that shield, perfectly shield, but still okay because we got very good amplifiers. Okay, and the power amplifier is of course to collect signal from the patients, and then so as to we say analyze by the machine. Okay. And it's easy to use. I'll tell you later on how it's easy. I really like the latest ideas of how helping the clinicians uh, by the Celesta. Okay, and it's used USB connection through just a single USB cable. I when I was just graduate from the audiology program, like like uh, more than 15 years ago, and for every audiologist, our nightmare is whenever you get into the clinic, you got lots of cables and you have to tidy up every cable every day so as to make it neat and tidy. But now we got just very little cable, like one or two, very easy to handle, very tidy, decent performing um, nowadays. Yeah, not just like a long time ago, we got every time. When you're performing tests or whatever, you got 5 to 6 sets of cables. Okay. So the Celesta is very helpful. It's designed for daily clinical practice and less technical preparation to shorten your technical preparation time, faster setup, and more stable recordings, and easier to for you to check out curves. Okay, so there's a push button on the power amplifier here. Okay, for the left one is to check the impedance, and then you start or pause your test. You stay with the patient and you do not lose the electrodes. Just like checking in the middle of the test, you can check the impedance and then you pause the test, and you won't like just after in the middle of the test when you want to stop and then to check the impedance, then you have to go back to start the test all over again. It doesn't work like this. After you check the impedance, you can go back to the test and then continue your test so as to save your time. Okay. So, and then you do not have to interrupt the child because there's a button already on the amplifier, the power amplifier. You can focus more on the patient or maybe the parents, not on the keyboard. Okay, so we also have the automatic side switch, one channel mode. Okay, so what this really help is because for some cases in like you're helping a kid, a young kid, to check the maybe the ABL, and then you check the ABL, and then you have to like turn off the light, right? The child is sleeping. You don't want to wake the child, wake him up or wake her up, and then you have to dim the light, and then you have to put on the channel, uh, the electrodes one by one, and you don't really want to like put the cable again, right? So you don't want to make the child awake. So this is good to have the automatic side switch. So after checking one side, you don't have to put the electrodes again. Your the power amplifier help you to switch the electrode automatically. So there's no risk of cable inversion, not mixing up the cable, very safe. You're very confident for the whole test. Okay, you don't have to worry about whether the cable is put in wrongly. And then the automatic vertex short circuit so as to put the setup correctly. And then there's like guidance for the electro connection. Like after you rub the baby, or maybe you rub the child, you don't have to look at the screen, don't have to look at the monitor, okay, of the computer. You just check out the light, the LED light on the Celesta, the power amplifier, so that you already know when you put the electrode, whether the impedance is low enough for the test. Okay, so it's like this. For the active electrode is on the vertex, and one reference, one ground, red for right and blue for left, and then it switch the ground and the reference electrode itself. Okay, automatically. So you don't have to swap the cables in the middle of your test. Just focus on the patient, okay? And then later on, you check out the results. Okay, so there's two channel acquisition. So for one channel, we got only three electrodes, but for the two channel acquisition setup, we got five or four electrode with the shared vertex. Okay, this is shared vertex. This is five electrodes, but you just have to prepare one time. Then you can reduce the test time by half. Okay, and fewer wiring errors, faster preparation, and better comfort. Okay, just now we talked about not waking the child up. Okay, and also we don't use no longer use the white cable. Much more helping. Good enough. Okay, so just now we talk about the LED lights, green for correct connection, and then yellow, the impedance is a little bit high, and red is not helping. The test can't be started when it's in red. So when it's recording the test, all this LED turns off. Okay, so reduce the light so that the child is not waking up. Okay, and then blue is for checking the impedance. So here comes after we talk about the hardware, we talk about the software. The we use the Maestro software. If every one of you used the Inventis other equipment before, then I'm sure that you already know Maestro software. You must be heard about that. And Celesta, we like for this license, we got the full version. We got AVR, MLR, LR, ECOG, G, CVEM, and OVEM. And then for each of this module, you can choose your configurations here. Okay. And then some or if you like want to set up your new clinic, and you can really use the preset parameters, because all the preset parameters we set based on the scientific literatures. Okay, so you just choose the test and you maybe take a look and check out a bit about the preset parameters, and then you can go ahead for your clinical test. Okay, and you just select those tests. You don't have to configure yourself a lot. Very easy to use, and the parameters are already very optimized for your clinical practice. And then we use just only the USB-C cable and for both power and the control. So it's reliable and it's simple and decent. Okay, you push the USB-C already help the immediate installation. Okay, so for the positioning of the Celesta, we know that there are lots of other our um in the field, the audiology field, we got different brands, right? And then we'll position the Celesta as high customer value, but not very high price. Okay, of course, it's not very low price, but it's high customer value. We say it's high uh uh value and the price ratio. You know, value is different from the price. Sometimes you pay for high price, but maybe you don't really get the very high value. Maybe you just pay for the like if you buy a LV bag for ladies, you buy LV bag, or you buy a Goya bag, or maybe you buy a Chanel bag. Um, technically it's high price, but it's not very high, very useful bag for you. Maybe it's very look good, look decent, look very gorgeous, but it's not very that useful. The bag is very small bag. Okay, but for some cases, when you buy like say a big bag for your Goya, you can use it a lot. Although it's high price, a little bit high price, but it help you a lot for every daily situation, right? So for Celesta, I'll say is not low price, but not very high price, but it's high customer value. It covers all the, we say the EP, the ABL, uh, the LLR, the MLR, the ECOG, and the CVEM and the OVEM, and the best one, we got the Here Lab, which is I think is unique over in the audiology field. Okay, so the Celeste you always have a higher customer value, but not that very high price. Okay, so I'm quite confident for the Celeste, and it's stable, and because the Celeste is new, and it already exclude a lot of technical problem for very old machineries. Okay, so we hope if you get used to the Celesta, want to try to transform the EP diagnostic to a simple, integrated, easy to use, and patient-centered clinical workflow, but still, of course, very professional one. Okay, and we want to make sure both the clinician and the patient have a best experience with the Celesta, and then we get accurate results, and then we help the patient for the next step, like whether they go for intervention, which kind of intervention, and then maybe some checkup. Yeah, so this is what the Celesta designed for. Okay, so I'll talk about a little bit about the initial setup and connection, and then I'll pass back uh, uh, my sharing to the colleague. Uh, mhm. Okay, so this is the setup. Just now we talk about the setup. Maybe you can also have the bone vibrator if your kid, like the newborn baby, got the atresia or microtia, and you still want to know whether they can hear with a bone conduction test. Okay, so they can't hear well outside, not able to use the insert phones, just the headphones, and you check that there's a delay of the signal in the ABR, like only the signal only present at like 40 or 50 dB of the stimulus, the level of stimulus, and then you can switch to the bone vibrator. So then you check the ABL. Although it's kind of um kind of a little bit taking more time, you still can help your to accurately diagnose whether the baby really have some um um sensory neural hearing loss or just the conductive hearing loss due to the atresia or microtia. Okay, so and then you got a power amplifier, and then you got a main unit, and then the transducers, the van monitor, and bone vibrator if needed, and of course not needed for every time if you got a kid with finally normal hearing. Um, yeah. And then the channel one, the channel two, the on the power amplifier, and the 4 to 5 electrodes. Yeah, this is the guide of how to check out the LED lights. Okay. And some troubleshoot if you see the purple blinking light, which talk about the battery, the power is not sufficient. And in the past, we got remember this impedance place? We check the impedance calibration, and after check the calibration, and then you check with your real patient the impedance. Okay, so this is the recommended values of the impedance. Yeah, and this is the demo pictures. Mm-hmm. And then for this part, I think we talked about that a little bit before. It's like you rub the skin, and then you place the electrodes to ensure with the gel, the conduction gel, so to ensure good electrode contact. And then you run the impedance test before you start the recording. Yeah, you can take a look at the Maestro, the software, or you can just take a at the power amplifier. Okay. And then of course you put the stimulus like through the inside phone or whatever, and or the headphones or the bone conduction, or maybe later on the free field. And then recommend values will be this one for the impedance. If the impedance is higher than 5K ohm, then we recommend you to rub the skin again and check the electrode contact. Okay. So for the stimulus available in the Celesta, we use click, tone burst, the chirp, and the chirp family, which is quite exclusive in the Maestro. And different kind of stimulus will be used in different tests in different setup. Okay, and then remember the Maestro software, it already designed the pre-designed the parameters. So you don't have to like check out your books, check out your study materials every time for the stimulus. You just choose those preset parameters, then it will already help because it's follow the scientific literatures. And then this is some spare clinical overview. If you have time, then you can check out the like what ABR and then BEMs are, and they're different kind of setup. Okay. So so for the positioning, we talk about the why Celesta is very competitive. It's because we have here lab is unique over the audiology field, and it really helped to like evolution of how to help very difficult cases of fitting hearing aids. Okay, and or not even fitting hearing aids for babies. You want to know the real time when they are like they don't even need any cables on the baby so as to check their hearing. Then you can use the Celesta. Just a few cables, not even wearing the headphones, okay? So the future modules will be ASSR, and I think for the other point for fitting hearing aids is we want to know frequency specific information. So after okay, we got a baby, and we know ABL they got hearing problem. Okay, and then we have to fit hearing aids for the kid so that to help their speech and listening development. And then but when we fit hearing aid, we need frequency specific threshold information. So later on, the Celeste will have the ASSL module as well. Okay, so here comes some questions from the field to check out. Some we say the troubleshoot. Maybe if you have time, you can take a look at that. I prepare a lot for today's presentation, but I don't think I can finish it within 1 hour. Yeah, of course, I share the presentation later on so that the colleague will translate it in English, and then you will have the full version of my presentation. And thanks for attending the presentation today.